Disseminated intravascular coagulation and ITP. We're going to be looking at perfusion and immunity during this clotting exemplar. The interrelated concepts are going to be clotting and gas exchange. First of all, we're going to talk about DIC. What is it? Disseminated intravascular coagulation. This is basically an issue with the clotting process, and it's potentially a life-threatening condition where there's a potential for thrombosis and hemorrhage at the same time. This can be acute or chronic. We're seeing hypercoagulation of the blood with consumption of all the clotting factors, so they're all being used. In the development then of the microthrombi, we have an extensive abnormal clotting occurring, and this again depletes the clotting factors and all those platelets, but at the same time, extensive bleeding is occurring from many sites, and this can be just a consistent oozing or a fatal hemorrhage. Clots will begin to block the blood vessels and decrease blood flow to the tissues and major body organs, leading to pain and ischemia. DIC is always a secondary condition. So risk factors can be pregnant clients that experience complications of preeclampsia, placental abruption, fetal demise, amniotic fluid embolism, aseptic abortion, or the HELLP syndrome. Other risk factors for DIC include infection, especially sepsis, cancers, and some really significant injuries from trauma or burns. Now, chronic DIC is most likely associated with severe organ damage related to another condition and or malignancy. So with acute DIC, this is going to be characterized by bleeding, renal, hepatic, and respiratory dysfunction, in addition to shock. With the chronic issues, this is characterized by malignancy history, venous or arterial thromboembolism without an identifiable cause, and mild thrombocytopenia. Now, clinical manifestations that occur in both acute or chronic issues include petechiae, purpura, ecchymosis, bleeding both internally and externally, pallor, cool extremities, cyanosis of extremities, pain, ischemia, stroke-like symptoms, dyspnea, tachycardia, reduced kidney function, and bowel necrosis. Now let's look at these symptoms a little bit and let's figure out what's going on. So with the petechiae, the purpura, the ecchymosis, the bleeding, this is all caused because we have depleted our clotting factors. We no longer have the ability to form those clots. With the pallor and the cool extremities and the cyanosis, this is because now we're becoming anemic. We're bleeding out, so we don't have the volume to perfuse the different areas. So our skin shows by becoming very pale, becoming very cool to the touch because of the lack of blood flow. And again, cyanosis because we don't have that perfusion. With pain and ischemia, those are caused by those microemboli that are floating around through our circulatory system, blocking off blood flow to specific areas. Um, so this could also lead to the pallor and the cool extremities and the cyanoses. Um, Remember, one of the main symptoms of ischemia is going to be pain. We may have stroke-like symptoms if those clots lodge somewhere in the brain. Dyspnea, for a variety of reasons. First of all, it could be clots that are causing some issues with the gas exchange. It could be that uh, our bodies are just working harder to get oxygen into the body so we can perfuse it because we have a decreased blood volume, or we have a lack of oxygen to certain areas. Same way with the tachycardia, the heart is working harder trying to perfuse the body. Reduced kidney function um, could be because of those micro emboli. It could also be because of the hemorrhage. We are losing the volume, so the kidneys start to reabsorb fluids, slowing down the urine output for the simple fact that it's trying to hang on to that fluid to keep the body alive. And bowel necrosis could potentially be caused by those microemboli. So the different labs that we might do would be the ProTime or the PT, the activated partial thromboplastin time or the APTT. Those are both going to be prolonged. A positive D-dimer shows the presence of clots. A decreased fibrinogen and platelet level, so our clotting factors are now decreased. And a CBC may indicate a low hemoglobin and hematocrit in addition to that low platelet level. Common causes, again, it's really important to be familiar with the common causes because it's going to assist us in guiding the treatment. Remember that DIC is a secondary condition, and we need to know what instances it could potentially manifest so we can be monitoring for symptoms and potentially help prevent them. So with acute DIC, remember this will occur rapidly over hours to days, and it's often seen in the pregnant client with complicated pregnancies by preeclampsia. That infection, especially if it goes septic, and it can be viral or bacterial. And then again, the severe trauma, whether it is from, for example, a motor vehicle accident, an explosion, burns, etc. And then chronic DIC will develop slowly over weeks or months. And remember that cancer is going to be the most common cause of chronic DIC. Prioritizations. We need to treat the underlying disorder and prevent any further bleeding and thrombosis. So what are we going to do? Well, first of all, we need to promote effective tissue perfusion, monitor the gas exchange, manage the client's pain, manage their fear, and manage skin integrity. This will require close monitoring of those clients that are at risk so we can hopefully catch any early signs or symptoms and ward it off at the pass. Treatment of the underlying cause. This is also going to require close monitoring of the vital signs, the skin and the mucous membranes for signs of bleeding. Changes in the level of consciousness, which can be from a lack of oxygen or perfusion. Diminished pulses, chest pain, and decreased oxygen saturation. All of these can indicate clotting and oxygen deprivation. If we do see bleeding, remember that the first and foremost thing we do is apply pressure. We may be administering heparin during the early phase to help limit clotting and prevent that rapid consumption of those clotting factors. If it is COVID-19 as one of the precipitating factors, a low molecular weight heparin in those hospitalized clients that are not critically ill are often administered. Clotting factors later in the progression of the DIC will be administered when hemorrhage is that primary problem. And we obtain those from fresh frozen plasma, the cryoprecipitates, and platelets. We may give packed red blood cells to help replace the blood, oxygen, and these clients may require mechanical ventilation. IV fluids, and these will be crystalloids, colloids, and protein-containing colloids. Again, monitor those vital signs, monitor the skin and mucous membranes for color, monitor for cognition, and definitely monitor urine output. Urine output will be a good indicator of perfusion, especially to the kidneys, but perfusion in general. Advanced monitoring would include hemodynamic monitoring, such as the central venous pressures, arterial pressures, mixed venous oxygen saturation, and pulmonary artery monitoring. Some of the medications that we may give would be some vasoconstrictors, some inotropic agents to help improve the function of the heart, or agents to help improve myocardial perfusion, and vasopressors to help support the blood pressure. And of course, an indwelling urinary catheter so we can monitor the I's and O's carefully. With evaluation, ultimately the goal for a client with DIC is that the client's body survives and is now capable of keeping the client's oxygenation needs, perfusion needs, and clotting needs in check, that everything is working appropriately. So idiopathic, also known as autoimmune thrombocytopenic purpura, uh, often called ITP, is a destructive reduction of circulating platelets, but we have a normal platelet production. ITP is considered an autoimmune disease, and the client's immune system makes antibodies that attack the client's platelets. So remember, with our immune system, when it detects something that is foreign, then the immune response is activated, and our body's immune response tries to get rid of that foreign object. But when we have an autoimmune issue, the client's immune system is not recognizing the self as belonging to the self. It's recognizing it as something foreign, so it now begins to attack itself and destroy itself. So in this issue, the platelets. The client's clotting ability will definitely be disrupted because of this issue. ITP can be acute or chronic. The chronic issues will be more common in the adult. It is most common in women that are 20 to 50 years of age and among people that have other autoimmune diseases. These clients often present with large ecchymosis or purpura, and remember that purpura can be more of a purplish discoloration to the skin caused by some bleeding. We may see it on the arms, the legs, the upper chest, the neck. We may see bleeding of the mucous membranes or blood in the stool and urine. These clients will most likely be anemic. So we're going to do a CBC, and we will expect to see a low hemoglobin and hematocrit along with low platelets. We may also see antiplatelet antibodies present with a deeper dive into the blood studies. So what do? We're going to monitor platelet levels, and in mild cases, that may be all that we need to do. With other cases, we may need to do platelet transfusions, especially for levels that are below 10,000, or there may be a life-threatening bleed. It may require us, or it will require us to maintain a safe environment, and this means we're instituting bleeding precautions. So what are bleeding precautions? Making sure that we're preventing anything that could cause bleeding. So no sharp razors, minimize needle sticks, using a soft bristled toothbrush, etc. Drugs that suppress the immune system may be administered, and this would include corticosteroids, immunoglobulins, or medications to facilitate the production of platelets, etc. Surgical interventions may include a possible splenectomy if the client does not respond to drug therapy. But understand that there is an increased risk of infection if the spleen is removed. So now we have a case study with a 59-year-old who is a 3-day post-op client. The nurse is caring for a client who's 3 days post-op after a colon resection. The nurse is delegated to the UAP to take morning vital signs. At 8 o'clock, the UAP reports the client's oral temp is 101.6. What is the nurse's priority action? Well, the nurse needs to go to the client's room and perform a complete assessment. Determine what might be going on here. Are there too many layers on the client? Does the client have a potential infection? So this requires doing an assessment of the wound and reviewing labs. But we also need to reduce that temperature. So remove some layers, decrease the room temperature, cool cloths or packs to the forehead, the neck, the axilla, the groin, putting a fan on the client, administration of antipyretics, especially liquids at this point. Suppository may not be appropriate depending on where the resection was. If it was low in the colon, then suppositories may be contraindicated because of potential damage to the surgical site. Upon assessment, the nurse notes the client is flushed and slightly diaphoretic. The client appears lethargic but does respond to simple questions. Other vital signs include a blood pressure of 90/40, a heart rate of 134, respiratory rate of 26, and they're deep, and the temperature has now increased to 102.8. The lungs are clear to auscultation through all lung fields. The client's abdominal wound has a dressing that's moist with a moderate amount of purulent drainage. The peripherally inserted catheter or the PICC line is intact. So how do we interpret this data? Well, we definitely want to consider the development of an infection based on the operative history, the vital signs, the purulent exudate. We have tachycardia, we have increased respirations, we've got that purulent drainage, all of those are concerning to suspect an infection. The surgical dressing should not contain purulent exudate. And now we also have hypotension added on to that. So something more serious could be developing. This client could be becoming septic. Um, so we need to really be looking at this client. We do know that we are going to have some elevation of the heart rate and the respiratory rate just because of the elevated body temperature. When we have an elevated body temperature, that is indicating we have increased metabolism. So part of increased metabolism is an elevated heart rate and respiratory rate. But again, that low blood pressure is very concerning. So 20 minutes later, the nurse calls the healthcare provider to report these abnormal findings. Provider orders are acetaminophen, 650 milligrams PO/PRN, every 6 hours for a temp above 101. Blood cultures times 2, one peripheral and the other from the PICC line. Collect wound cultures for culture and sensitivity of the abdominal wound drainage. And vancomycin, 750 milligrams IVP over 1 hour. And this is usually a twice a day thing. So rank the order in which the nurse should complete these interventions. Well, what do we do? Okay, so first of all, we really need to initiate that sepsis bundle, which we'll talk about a little bit more when we get into shock in Module 3. But understand with the sepsis bundle, that means that we're going to be doing blood cultures, we're going to be doing wound cultures if necessary, and administering antibiotics within 1 hour. Then part of that sepsis bundle is then potentially administering some IV fluids. So based on that, we know that we always want to obtain our cultures prior to the administration of any antibiotic, but we need to do this as quickly as possible. So we need to get those cultures. Blood cultures sometimes are done by the nursing staff. Sometimes the phlebotomist from lab will come and do that. So if lab is going to come do that, we could, in the meantime, get the wound cultures so they're available for the phlebe to take back to lab. How do we obtain a wound culture? Remember that you always have to cleanse the wound first. And we cleanse it with normal saline. Do not cleanse it with anything else. So cleanse the wound with normal saline, remove any old exudate that is there, and try and express some fresh exudate. But if you can't, just swabbing the wound itself, the areas where there might be some, where you might have seen the exudate coming from, especially. Blood cultures, remember when we do blood cultures, we're going to get those from 2 different sites. We do not get them from the same site, but the provider has ordered one of those to come from the PICC line, so and one peripherally. Then we're going to get that antibiotic started. We need to get that going as soon as possible. And then we would administer the acetaminophen and then do some of the other interventions that we talked about to decrease the client's body temperature. Over the next hour, the client continues to decline with a decreased level of consciousness. Temp is now 103.8. Blood pressure is 80/40. Heart rate is 134. Respers are 34. The nurse calls the provider to report these findings and obtains orders for the client to be transferred to ICU. When preparing for this transfer, the nurse notes that the O2 saturation is 87% on room air. So what is the priority action? Do we draw that arterial blood gas sample, apply oxygen at 2 to 3 liters per nasal cannula, administer acetaminophen 650 milligrams by mouth, place the client on a cardiac telemetry monitor? Well, remember, we're going to do the least invasive first. So I'm going to get the oxygen on this client. This client is unstable, and right now the priority action is the oxygenation status. The client does have that rapid respiratory rate and a low SpO2. We need to give him oxygen and then reassess shortly afterwards to determine if that oxygen is making a difference, because we may need to bump up that level. But we need to do this prior to transferring the client to ICU, meaning that the client will be transferred on oxygen. Once the client has stabilized, then yes, we do need to get that telemetry on them, especially during transport, if at all possible. We may not be able to wait for stabilization to apply that telemetry and to do the transport. We can request an ABG sample, but I'm not going to do that right now. Let's get them to ICU first, where they're better equipped to care for a client that is in this critical state. The client's elevated temperature also needs to be addressed, but that would be the last thing we do. So at any time during this situation, we can call rapid response team to help stabilize this client, even though we do have that order to transfer to ICU. Our blood pressure is 80/40, and that is pretty doggone low. So we may need to do some other interventions to help get them a little bit more stable prior to transport. Again, if this client is on the medical unit, the nurses on that floor usually do not have the training or the capability of dealing with these critical issues. So having rapid response might be very beneficial. Within 30 minutes of the client's transfer to ICU, the client's condition continues to deteriorate. The SpO2 continues to decrease. Respiratory rate is 36. The ICU nurse notes there's blood oozing around the PICC line catheter. An indwelling catheter is inserted. The urine output is 25 and dark amber. What is the interpretation of these assessment findings? Again, this client is most likely septic. We see the higher temperatures with sepsis than we do with just an infection. But we also have that low oxygen saturation, the elevated respiratory rate and heart rate, the low blood pressure, the low SpO2. These are very abnormal, and we do suspect that the surgical wound is the site for the septic infection. But now we're starting to see some signs of blood oozing around that PICC line catheter. This could indicate the start of DIC. This client is likely going to require some vasopressors, definitely some IV fluids. The client will most likely be placed on mechanical ventilation in addition to doing other supportive care.